All right, today we're diving deep into the clinical morphology and differential analysis of cerebrospinal fluid. We're going to go on a journey from just looking at basic cellular patterns all the way to gaining some really powerful diagnostic insight. Our whole goal here is to figure out how a qualitative look at CSF can help us pinpoint all sorts of things: infections, malignancies, inflammatory conditions. It's one thing for an automated counter to give you a number, but it's the morphology, the story the cells are telling, that really reveals why something is happening. So we're going to cover the whole process, from getting the sample ready all the way to making that critical diagnosis.
So here's our game plan for today. First, we'll talk about why morphology is so important in the first place. Then, we'll get practical and look at how we get from a liquid sample to a readable slide. After that, the real detective work begins, decoding the cellular landscape. We'll then tackle the really tricky stuff, identifying cancer and the things that look like it. And we'll wrap it all up with a neat diagnostic summary. Let's jump right in.
Okay, let's kick things off with Section 1, Why Morphology Matters. This is all about moving beyond just the raw numbers, to really see the full picture of what's going on inside the central nervous system.
Think about it this way. On one hand, you have the quantitative approach. It's like a calculator. It gives you a number. It answers the simple question, is there an issue? But that's it. It's not very specific. But on the other hand, the qualitative analysis, looking through that microscope, answers the real question. Okay, what is the issue? This is where we get our diagnostic power. This is how we can tell the difference between a bacterial and a viral infection, how we can spot malignant cells, or identify something like multiple sclerosis. To put it simply, the numbers might tell you there's a fire, but morphology shows you exactly what's burning.
And this right here, this is exactly why using a stained smear is absolutely non-negotiable. Just look at the difference. On the left, in a counting chamber, the cells are just, they're fuzzy blobs. And this leads to a golden rule. You must never perform a differential count in a hemocytometer. Why? Because you just can't see the morphologic detail. Now look to the right. With a properly stained smear, suddenly everything pops into focus. You've got diagnostic clarity. You can see the nucleus, the cytoplasm, the whole shebang. If you skip this step, all you can say is, oh, there's a certain percentage of mononuclear cells. You risk completely missing the big stuff: malignant cells, blast forms, reactive lymphocytes, or those telltale macrophages with inclusions.
Okay, so we know why we need a good slide. Now let's get into the how. Section 2, From Sample to Slide. It's all about mastering the techniques to get the best possible analysis.
The biggest challenge with CSF is that it's naturally low in cells. It's mostly fluid, so we absolutely have to concentrate them. The solution? The Cytocentrifuge method. It's a really elegant process. As you can see, first the sample gets loaded. Then it's spun down in a centrifuge, which gently pushes the cells onto the slide. A special filter blotter soaks up all the extra fluid, which is great because it keeps the cells from getting squished or distorted. And what you're left with is a perfect, highly concentrated single layer, a monolayer, of cells with their morphology beautifully preserved, all ready for an accurate diagnosis.
But getting that perfect slide takes a little more finesse. For specimen prep, a great trick is to add a single drop of 30% albumin to the CSF. Think of it like a little pillow. It cushions the cells during centrifugation, which means you get more of them on the slide, and they look a lot better. Now, beyond prep, you have to be an expert at spotting artifacts. The cytocentrifuge process can sometimes create things like this mechanical clumping you see here. To the untrained eye, that could look a lot like a malignant cluster. And this brings us to the golden rule. You have to examine the entire slide. Look at the center, look at the edges, because you need to be able to tell the difference between a real finding and a simple artifact.
Right. So before we can start hunting for abnormal cells, we have to know what normal looks like. This is our baseline. In a healthy adult, the CSF is made up almost entirely of lymphocytes and monocytes, in about a 70-30 ratio. And for pediatric patients, it's pretty similar, still mostly those two cell types. Now, it's also worth noting that it's okay to see a few neutrophils here and there, especially with these high recovery techniques we're using. But for the most part, when you look at a normal CSF, you expect to see lymphocytes and monocytes. They're the normal residents.
Okay, Section 3, Decoding the Cellular Landscape. We've got the basics down. Now the real detective work begins. This is where we learn to interpret the abnormal findings that lead us to a diagnosis.
Often, the very first sign of trouble is something called pleocytosis. The definition is really straightforward. It's just an abnormal increase in the white blood cell count in the CSF. But here's the crucial part. We have what's called the diagnostic triad. The increase is usually dominated by one of three main cell lines, either neutrophils, lymphocytes, or monocytes.
Figuring out which of these cell types is taking over is what points us in the right direction and really determines the underlying pathology.
So let's say you're looking at a slide, and it is just loaded with neutrophils. What's the first thing that should pop into your head? Bacterial meningitis. That's your #1 suspect. Now, sure, there are other possibilities. You might see this in the first 24-48 hours of a viral infection, or as a reaction to a brain bleed or a shunt, but morphologically, your alarm bells should be ringing. You might see some neutrophils with a pycnotic nucleus, which is a sign of cell death. Just be careful not to mistake that for a nuke RBC. But the single most important thing, the absolute definitive sign of a bacterial infection, is seeing a neutrophil that has actually eaten bacteria, phagocytized bacteria, just like you see in that third image. That, right there, is the smoking gun.
Okay, let's switch gears to our lymphocytic and monocytic patterns. When you start seeing reactive lymphocytes, like the one here with that classic deep blue cytoplasm, your differential diagnosis should include things like viral, fungal, or tubercular meningitis. But when you see plasma cells, like the one on the right with that very distinct off-center nucleus, you need to think about something very specific: multiple sclerosis. In fact, the classic pattern for MS is a moderate increase in white cells with both lymphocytes and plasma cells present. High numbers of lymphocytes can also show up in other conditions like HIV/AIDS or certain degenerative neurologic disorders.
Now, there are two other important cells to keep on your radar: eosinophils and macrophages. Eosinophils, with those unmistakable bright reddish granules, are a big red flag for parasitic infections. You can also see them in some fungal infections, like Coccidioides immitis, or in reactions to foreign material, like a shunt or contrast dye. And then you have the macrophages. I want you to think of these guys as the cleanup crew. They show up about 2 to 4 hours after red blood cells get into the CSF, and their job is to get rid of all the debris. So, seeing them doesn't mean there's a fight happening right now. It means they're reacting to something that's already happened. They're historical markers.
And what these macrophages clean up tells a fascinating story, especially after a brain hemorrhage. This lets us actually decode the timing of the event. Stage 1, on the far left, is called erythrophagocytosis. That's a macrophage that has just gobbled up a red blood cell. This tells you the bleed is very recent. Then, as that red cell gets broken down, you move to stage 2. You start seeing these dark, iron-filled hemocyterin granules inside the macrophage. That tells you the breakdown process is well underway. And finally, after even more time has passed, you see these beautiful golden yellow, iron-free hematoine crystals. This is the sign of an old hemorrhage. So by looking at these inclusions, the lab can give a pretty good estimate of when a cerebral hemorrhage happened.
All right, Section 4. We're now moving into what is, without a doubt, one of the most critical and challenging parts of CSF analysis, identifying malignancy and its mimics. This is all about telling the difference between true cancer and benign cells that can look alarmingly similar. So first, let's talk about the pitfalls, the imposters. These are the non-pathological cells that can trick you into thinking you're seeing malignancy. You'll often find them after things like neurosurgery. We're talking about choroid plexus cells, ependymal cells, and spindle cells. They can clump together in these clusters that, at first glance, look pretty scary. But here's the key feature you have to look for: uniformity. Unlike a malignant cluster, these benign cells are all pretty much the same size and shape. Your job is to recognize these for what they are, benign, because a false positive cancer diagnosis is absolutely devastating. Now let's look at the real deal, true malignancies that originate in the blood. On the left, we have our first wanted poster for blast cells. You're going to see these in acute leukemias. They could be lymphoblasts, myeloblasts, or monoblasts. The key features to look for are their really prominent nucleoli and their large size. Then on the right, our second wanted poster is for lymphoma cells. Finding these means a lymphoma has spread to the central nervous system. They have a very characteristic look, with these cleaved or irregularly shaped nuclei, and you often find them hanging out in a mixed population of other cells.
Now, it's not just blood cancers we have to worry about. We also find malignancies that are non-hematologic. These are typically metastatic tumor clusters that have traveled from a cancer somewhere else in the body, think lung, breast, or GI tract, or from a primary brain tumor. These clusters have what we call a malignant signature. There are 3 things to look for. 1, they have fused cell borders creating a syncytia. 2, the nuclei are hyperchromatic, which just means they're very, very dark. And 3, they have irregular nuclear contours. The absolute critical skill here is telling these apart from those benign clusters we looked at earlier. And remember, if you are ever in doubt, that sample needs to be sent to pathology for confirmation.
Okay, last section. Section 5, Diagnostic Pattern Recognition Summary. Let's pull all of these threads together and see how these different patterns form a really definitive diagnostic tool.
So think of this as your cheat sheet. By identifying the main cell or feature on the slide, you can immediately zero in on the most likely condition. You see mostly neutrophils? Think bacterial meningitis. A ton of lymphocytes? Think viral, TB, or fungal meningitis. You spot plasma cells? Multiple sclerosis should be high on your list. Eosinophils? That suggests a parasitic infection or maybe a shunt reaction. Macrophages filled with hemocytorin? That's an old hemorrhage. Blast cells? That's acute leukemia. And those ugly malignant clusters? You're looking at carcinoma or metastasis. And this, right here, is the incredible power of morphology. It transforms a simple fluid sample into a window, giving us a direct, unfiltered view into the health of the central nervous system.